Well, hello, everyone. Hello, Robbie. How are you doing today?
I'm doing great, thank you.
Thank you very much for your time. I will try to introduce your enormous CV, to the audience. Robbie is a giant of pediatric critical care medicine. Many of us look up to you and your work, Robbie, from many time ago. So thank you for your time. Robbie is an associate research director in the Intensivist and Attending Physician in the Department of Anesthesiology and Critical Care Medicine in the Children's Hospitals in Los Angeles, California. He's also full professor of pediatrics in the Keck School of Medicine of the University of Southern California, and he has been involved in many groundbreaking studies in the area of pediatric mechanical ventilation, lung injury, respiratory physiology, both translationally and at the bedside. Today, I wanted to talk with you, Robbie, about another groundbreaking research initiative of which you are the senior author and chair, the first pediatric ever mechanical ventilation liberation guidelines. So my first question to you in this chat is why? Why did you choose the liberation of kids from the ventilator as a key, or why did you focus on this research area?
Yeah, so first of all, thank you. Thanks for inviting me. This is exciting. I've never done a podcast like this, so I'm excited to do it. And thanks for organizing it, Sebastián. It's wonderful what you're doing. So why this topic? I think that this topic is, something that's near and dear to almost all of our hearts, right? Anybody who is a practicing pediatric intensive care practitioner likely gets frustrated by our lack of evidence in many areas and our variability in what we may do for patients that are on ventilators, and in particularly how to get patients off of ventilators. It's been a source of frustration, I would say, for me, even from when I was a clinical fellow, where I was very focused often on the idea, post-extubation upper airway obstruction was something that frustrated me as a fellow, that you got to this point where this patient was ready to be extubated, everything looked great, you weaned, and then you had to re-intubate them after they failed from upper airway obstruction. And looking to the literature, I felt, we didn't have all the data that we needed. So that's what sort of prompted us to say, okay, we need to really take a close look at what data exists in the various ventilation practices that we do, from when we start to wean the ventilator to post-extubation support, because we do things differently across all of our institutions. And what is the evidence that's out there to guide what we should be doing, so that we can either create recommendations, some of which we've been able to do, but then also really to identify what do we not know, right? What are these areas that really need us to focus our efforts and our energy on in the next 5, 10, 15 years, to come to more definitive answers for some of these areas. So that was really the reason. And
it was born from a frustration. I mean,
yeah, absolutely. I think Samer had a similar frustration, and his approach, has always been on the quality improvement side. Samer has done a lot of work with quality improvement, and in fact, it was his initial brainchild to say, on the QI spectrum, he struggles to be able to understand, what is an appropriate length of ventilation for patients? What's an appropriate extubation failure rate? What should the interventions be that we start to implement? We know that if we implement things in a standardized way, oftentimes outcomes will improve, but really what are the best things that we should be doing? And that question, we felt like we needed to synthesize the evidence first, and the existing evidence to know where to start from. Yeah.
And what makes you more worried about too soon or too late to extubate those children? I mean, what is more important in your view, or what has more clinical impact in the PICU? Those children who fail to be extubated when ready, or those kids who failed the extubation and the clinical outcomes worsen?
That's a hard question to answer, and I think it's hard because it's very dependent upon the patient, right? There are some patients where I would say the risks of extubation failure in this particular patient would be very large impact on that patient, right? Or on us as the healthcare system, right? You can think about this for relatively high risk patients that are maybe difficult to reintubate, for example, patients that might struggle with issues with de-recruitment or a neuromuscular weakness, for example, where you reintubate them and there's a setback for some period of time. So in those types of patients, maybe those very higher risk kinds of patients, then to me, I value extubation failure as the worst outcome, right? I would want to prevent that. As I think about lower risk patients, then I think maybe it's more along the spectrum of the impact on the healthcare system, right? There are a lot more of those patients, and if we can reduce their length of ventilation even by 12 hours or something like that, let's say, but it's 60 or 70 or 80% of the patients, right?
Yeah.
Then that has a bigger impact on the on the overall throughput of our ICUs, the healthcare system, but even more, maybe that has an impact on, for the patient long-term. I don't know what the right answer is for the long-term effect of, how long extra on the ventilator may have an impact on a patient's outcome, right? We know certainly risks of complications go up the longer you stay on the ventilator, even incrementally, 12, 24 hours, there's probably higher risks of complications from developing. Maybe there's adverse events with long-term outcomes, and this is, I think, an important area that we need to focus on to say, is it true that the longer the lengths of ventilation, the poorer the longer-term outcomes are? That's I think still an unanswered question in long-term outcomes work that we have to know really what that impact is of one additional day, So my answer is both. Right? I value both of those outcomes as important, perhaps one more important in one type of patient and one more important in another type of patient.
Why do you think that it took us so long to arrive to these guidelines? I mean, adult patients have many prior guidelines to liberate their patients, their adult patients to but we took a long time to reach this point and to say, well, let's get together. You and Summer led this amazing effort, and well, we have to discuss this. We have to review the evidence. So why do you think it took it so long?
Yeah, it's a good question. It's not from lack of interest, I think, right? So ventilator liberation, I think, has been a topic in the literature, for 20, 30, 40 years, even, as we sort of think about what are the right ways to liberate these patients. And some of the early work that I think is still really relevant today about spontaneous breathing trials and measures of extubation readiness and those sorts of things, were done 20, 30 years ago, right? So some of this work has been happening for a long period of time. I think that in more recent years, the last 10 years or so, there's been an increasing push to gain international consensus on ideas and on topics related to pediatric critical care and pediatric critical care research. So I think with the growth of the global research community, breaking down of sort of barriers and silos that exist from country to country or region to region, right? And increasingly there are more and more international efforts, right, to try to say, can we at least work together on this problem internationally, right? And so I think as that started to build, with a number of consensus conferences that have been done with head trauma, with acute lung injury, with ECMO, with transfusion, et cetera, then it sort of follows that we can use the existing framework in some capacity to now apply this to the topic areas that really do deserve that international attention. So I don't think it was because of lack of interest in the topic. I think it was just we got enough critical mass now sort of assembled of people that care about the topic, and we have a methodology with these sort of Institute of Medicine based approaches for clinical practice guidelines, and using international collaborators from everywhere to try to create these as an internationally appropriate set of rules.
Perhaps these international efforts and these research networks, which have been working really hard during the 10 years or so, perhaps variability of care and setting our common goals, our common problems, have been the light to set this fire. I mean, to try to put this kind of, well, let's get together, discuss together, and it will be important. What has been your experience as a researcher and as a lead of this international panel? What have you learned in the process of this last almost 3 years of work in the midst of a pandemic, trying to work a lot via Zoom, like we are now, building these guidelines?
Yeah.
What have you learned? How your clinical practice changed before? How was it before, and how it changed the process of making these guidelines? Did it change it or not?
Yeah, I think it did. There are a lot of things that I learned. Some of them which are on the clinical implementation side, right? Of what should I actually do when I'm thinking about liberating a patient. But then there are a whole lot of lessons that I think I learned about the whole process of doing work like this, and the importance of this process, but also how to approach this in pediatrics. So I think one of the comments that often come back when you say, okay, I'm going to do clinical practice guidelines, right, in a topic area, is we don't have any evidence. Why are we doing this, right? We don't have strong pediatric evidence to base, a lot of recommendations. We shouldn't even do clinical practice guidelines because they're all going to be speculation without any evidence, right? And having gone through this process, I really disagree with that statement. And I increasingly am disagreeing with it.
But
because
we have found many strong evidence, not so strong, but there is evidence out there, right?
That's right. Well, that's right. So first, right, we're only aware of what we know, right? So in that process, you will find studies that you didn't know about, right, that have been published. When you do this comprehensive literature search, then that uses a standard methodology and very explicit methodology, you'll come up with papers and you're like, oh, I didn't know about that paper, right? You think you're the expert in that area, but no, you will miss some things, right? So comprehensive literature search, most important. The second thing that I think is really relevant is the way the clinical practice guidelines now stand, and especially with the use of the grade methodology, right? Even when evidence is not strong in a certain area, the evidence to decision framework that exists within the grade methodology really makes you think about the intervention and the comparator very closely, right? And not just what is the evidence for one versus the other, but what are the effects on a number of different areas, the potential benefits, the potential harms that might exist, right? The implementation considerations. And even when you put a group of experts together, even when the evidence may not be strong in a specific area, but they're all very highly aligned on, there's very little harm from this potential thing. It would be very cost effective to do it. There are very few barriers to implementation. There really are no barriers to health equity, right? These kind of standard questions that everybody should think about and that the grade framework puts forward. Then sometimes it's quite clear, which direction we should have for the recommendation, even in the absence of very, very strong evidence, right? So that whole process has been really enlightening to me. And I would encourage, people to look very closely at that evidence to decision framework idea, because it is as transparent as possible to say, this is why we came up with the recommendation to do X, even if the certainty of evidence might have been low in that area. Yeah. So that's what I think I've really learned a lot on that implementation piece of it, for sure. On the clinical side, there are a bunch of other areas I think that are quite interesting there. I think some of the most interesting and provocative things have been, of course, the results of some of those network meta-analyses that I think were done for the questions about upper airway obstruction and post-extubation respiratory support. Yep, that's right. So I think those are the two areas where I've been starting to really rethink my practice with respect to use of post-extubation respiratory support and thoughts about steroids.
Okay, so I have had really nice feedback prior to this meeting with you. Many people have some question for you, so I throw some of them to you and let's see what happens. So, for example, from the UK, Hari Krishnan was thinking about, is measuring PI max without knowing what to do going to cause more confusion, disagreement, and likely delays in extubation? I mean, in your clinical practice, do you measure muscle effort? How can you recommend for those people for those colleagues who do not apply it? I mean, how do you approach those kids with muscular weakness, and what is the role of measuring PI max, for example?
Yeah, I measure it every day. I measure it all the time before I extubate somebody. There is not a patient that I don't measure it on for the most part. A few exceptions would be the patients that were not really covered in this guideline, right? The ones that are intubated for less than 24 hours, for example, right?
Okay.
But any patient that has been ventilated for more than 24 hours, I do routinely measure PI max. And I think about the two groups a little bit differently. I think about kids with pre-existing neuromuscular weakness a bit differently than kids that don't have pre-existing neuromuscular weakness, okay? First, on the reproducibility standpoint, right? It can be very highly reproducible if you do it, and you do it consistently. There's always been a concern, I think, that some people say, oh, well, if the NIF is low, I don't know if it's really, really low because of, patient cooperation or sedation versus if, the patient is actually weak. But if you do a very standardized approach to it, in fact, when the values are low, it really likely does mean that the patient has respiratory muscle weakness. The approach that I take, that we've published a few papers on this, so you can look to the literature to get them, is a continuous breath occlusion for 5 consecutive breath attempts, disconnecting the patient from the ventilator. So there's sometimes maneuvers on the ventilator to measure NIF where you can do a NIF or PI max measurement with all the ventilator tubing. I don't think those are very accurate, especially in smaller pediatric patients, so I don't advise doing that. We do a disconnection, hook up a manometer right at the endotracheal tube, and it's just a very simple $5 manometer. You don't need anything very complicated. And you do a continuous occlusion for up to 5 consecutive breaths. You don't let go in between. So this is going to measure at FRC. It's not going down to residual volume, which is theoretically how some of the PFT measurements are done. And you just take the maximum value that you get there. And that maximum value, there's a dose response relationship on the risk of reintubation, right? So, and this is how we think in medicine, right? We shouldn't think as if it's above 30, I should do something. If it's less than 30, I should do something else, right? If something's 29 versus 31, am I really going to make that big of a difference in my clinical practice about something? We think about this in terms of just putting and pooling the risks together of all the various interventions, right? So if I've got a patient that's got a low PI max value, let's say it's less than 20, and if you look at almost all of the observational studies
around 20
that have been cited in the guideline, in almost every study, if it's less than 20, that patient is very high risk, right?
Yeah.
If the PI max value is greater than 40, that patient is pretty low risk for having respiratory muscle weakness. And then in between is a gray zone. but that's normal, right? In the way that we approach critical care is that you often have a very low risk patient, a very high risk patient, and then an indeterminate kind of risk patient, which is how I would think about this with PI max. So if I have a very high risk patient with a low PI max, right, it doesn't mean that I'm not going to extubate them, right? Because ultimately,
that's an important message, because many times we measure many things and we say, hey, no, it's too negative, too high risk, I won't intubate it. No, man, perhaps you have to have a different approach with that very particular kid, right?
That's right. That's exactly right. So I say, okay, they seem high risk from a respiratory muscle weakness standpoint. Let's make sure all the other stuff looks good, right? So are they at high risk for upper airway obstruction? And we know that combination of upper airway obstruction and respiratory muscle weakness would be a bad combination potentially for that patient. So now I'm gonna think about doing what I can to prevent upper airway obstruction on that patient, right? Did they have a very marginal spontaneous breathing trial? They barely passed, right? They just were on that cusp, but I was still quite worried about them. Okay, maybe I take a little bit different approach to them. Or maybe this is the patient that I should extubate prophylactically to BiPAP or to non-invasive ventilation afterwards, right? Because respiratory extubation failure is a multiple compartment phenomenon. It's a multiple risk factor phenomenon. As you add more and more of these risk factors, they interplay with one another, and the patient's incremental risk goes up. It's rare that a patient who has no other risk factors and develops upper airway obstruction, their rates of reintubation are not very high. They're a little higher than the population average, but they're not very high. But if that patient also had a marginally passing spontaneous breathing trial and they have respiratory muscle weakness, now you've compounded these risk factors, and now they're a very high risk patient when you extubate them. Yeah, so that's how I would integrate the PI max variable is put it in context then to say, now know that this patient is going to fall on the higher risk standpoint. I want to make sure everything else is boxed up, and I want to think really hard about whether this patient should get post-extubation help. Yeah.
Nice. I would like you to elaborate. I recall many beautiful conversations between the panel in the panel about CPAP plus pressure support in the spontaneous in the SBTs, and I have learned a lot. So many people are asking, "Hey, we are not using PS anymore," and why is that? I mean, we have this kind of myth that children used to breathe through a straw, and we have nice study, observational study that might not be the case. And now in these guidelines, we changed that approach. What would you say to those people who do not believe about, well, only CPAP for those kids in the SBTs?
Yeah. So first, there was not enough, and I encourage people to read the details about the recommendation there, right? So the recommendation for a standard risk patient, right, would be you can do either pressure support or CPAP for a standard risk patient. And the reality of this is that our extubation failure rates for standard risk patients are relatively low, right? Generally, they're less than 10%, right? And so any incremental benefit in terms of accuracy of assessing what post-extubation work of breathing is going to be like, so I'll come to that point in a second, which is the reason we, for the CPAP, is probably not going to have a huge impact on that relatively low risk patient. And there may be, especially in the low risk patient, some subset of them that would look very good on pressure support. And then when you put them on CPAP, they may still pass in somebody's criteria, but they look a little bit more marginal, right? And the reality is that if you're used to extubating people from pressure support, they're going to look differently on CPAP than they are going to look on pressure support. So you have to also change your concepts about what a passing
it might be seen as counterintuitive,
That's right.
The higher risk the higher you demand from him to show you that he or she would be ready to be extubated. That's interesting.
That's right. That's right. So that's the correct concept, right? So if you have a patient that you're more worried about, right? You think that their risk of extubation failure is higher, then I want to see it before I take the tube out. Is this patient gonna struggle, right? I'm using the spontaneous breathing trial as the test. So I want to know, can you pass the test? I'm going to challenge you on this test, right? And what the physiologic studies show are that the post-extubation effort on CPAP is still actually lower than what it is after extubation by about 10 to 15% on average. On pressure support, it's 100% lower, right? So when you conceptually are extubating somebody from pressure support of 10, let's say, when you extubate them, their work of breathing is going to be twice as high as what it was on pressure support before you extubated them. If you use CPAP, on average, it'll be 10 to 15% higher, assuming they don't have upper airway obstruction. So that's and the physiologic studies support that strongly, right? But we don't have trial data, of course, to really know what the measurable impact is going to be on this for, rates of reintubation and total duration of mechanical ventilation. And so that I think is an important next step study that we should do. But I promise you can extubate patients from CPAP. I've done it in my clinical practice for 15 years. I don't use pressure support for spontaneous breathing trials. I use pressure support to wean patients, but I don't use pressure support as part of spontaneous breathing trials. And I think the physiologic concept of this breathing through a straw has been, I think disproven because remember, resistance is about flow. So when these patients are breathing during spontaneous breathing trials, they're not breathing with very, very, very high flow rates. If they are, I don't think you're going to be extubating them. It sort of indicates that their respiratory disease is still high. So then the resistance is actually still less through the endotracheal tube than what it is with the natural airway, right? Because we've put an endotracheal tube in that's bypassed all of the upper airway structures, right?
Yeah.
And so if you look at what's the resistance of the upper airway structures, that's taken out of the equation when you put an endotracheal tube in. But now you take the tube out, that resistance comes back, and actually the resistance when they're with the endotracheal tube at the flow rates around the time of the spontaneous breathing trial is still less than what you have with the upper airway. So that's why that CPAP estimation, I think, is more appropriate. Now, there's still some debate about,
go on.
Remember that CPAP on the ventilator, and most ventilators, is actually 1 or 2 or 3 centimeters of pressure support, just based on how CPAP works on most ventilators. It is not, CPAP that you would do with an anesthesia bag, for example, or T-piece, right? Which is why some places, if they really want to be purists about it, right, would say you should do this kind of CPAP with an anesthesia bag or with a T-piece, because even CPAP on the ventilator is providing a tiny little bit of pressure support, basically to trigger and to cycle. But the difference is probably only about 10 or 15% on work of breathing, which is why, just from a pragmatic standpoint, we use ventilator CPAP. Just it's clunky and difficult to make all those changes otherwise. Yeah.
Same happens with, after the publication of the guidelines, your group published about RDS patients and how the length of the SBT might be really important to detect and not overestimate the readiness to be extubated. Perhaps you could talk about a little bit more about that subgroup of patients that you detected, that we have to be really careful about the length of the SBT.
Yeah, the length of the SBT was an area where there was no evidence, if we look to our guidelines. So much so that we did a complete clinical appropriateness measure, right? So we tried to synthesize the evidence in that area about what's the optimal length of the SBT. and there have been no comparative studies, evaluating that, not even on an observational basis, really. And as we tried to pool the different studies, some studies had 30 minutes, some studies had 1 hour, and a lot of studies had 2 hours in the duration. And the lengths of ventilation and the lengths of extubation failure were kind of similar across all of those, because there's so much heterogeneity in these patient populations and in practices from unit to unit that it's hard to be able to get a signal from just, that one variable without controlling the other variables, right? So our practice in our unit has always been 2-hour SBTs. That's what our standard practice is. For any patient that's not, a simple extubation patient, like a seizure patient or something like that, that's been ventilated for less than 24 hours. So as part of we're doing an ongoing clinical trial in ARDS, and we do 2-hour spontaneous breathing trials to evaluate for extubation readiness as part of that clinical trial in both intervention and control arms. And we have, a lot of respiratory monitoring that's happening in those patients, esophageal catheters, and et cetera. And so, so we very systematically, as part of the study, are monitoring them continuously to say, when do they meet an objective failure criteria, during this SBT. That's based upon an esophageal catheter. It's based upon RSBI, desaturation, and tidal, all these factors. And what we find is that there's sort of 3 phenotypes of patients. There's the early failure phenotype. That phenotype is about 1/3 of the patients total, and they fail quickly within those first 30 minutes. And you look at them, and they look pretty obvious that they're going to fail. Right? They struggle almost from the beginning of the spontaneous breathing trial, and they're not really able to handle it by the 30-minute mark, clear failure criteria. But then there's these other 2 phenotypes, these groups that have a late failure, that fail between 30 minutes and 2 hours. And then there's the group that passes at the 2-hour mark. And it's sometimes quite difficult to differentiate between those late failures, the ones that fail between 30 minutes and 2 hours, and the passage group. And especially if you look at data only within the first 30 minutes to say, can I predict who's going to be in the passage group versus who's going to be in the failure group at the 2-hour mark, right? And again, that's not to say that we extubated those patients at the 2-hour mark. This is just to say, do they meet a clear failure criteria? And our failure criteria are quite objective, because they're based on, esophageal catheters and work of breathing. And it's very difficult to differentiate between them at the 30-minute mark. Their respiratory rates are similar, their tidal volumes are similar, their RSBIs are similar, their FiO2 needs are similar, right? Even their respiratory effort with esophageal pressure, similar. There's slight differences between the 2 that can be detected, but difficult to detect on clinical assessment at that point. So it's about a 50-50 chance at that point. Once they get to the 30-minute mark and they're passing at 30 minutes, still a good percentage of them will go on. I think 40% of them will go on to actually fail at by the 2-hour mark. So that's why I think a 2-hour SBT is most appropriate. If we think about it from the grand scheme of things, right, a 30-minute versus a 2-hour SBT, the difference between that on length of ventilation is minimal, right? Like, that's another hour, right? That's not the factor. The factor where this might come into play, of course, is if you were to say, I made a decision at 30 minutes, that patient was ready to extubate, and you actually went and extubated them, right? As compared to, I waited, they failed at an hour, right? So I didn't extubate them, right? And then looking at what the outcomes are in terms of differences between those 2 would be ultimately what we really need to do to figure out if that accuracy is better. But certainly if we just look at the objective SBT data, there's a good number of patients that fail after 30 minutes. So I think 30 minutes is not enough.
Robbie, just a few questions left. Many people was asking me or you, what criteria do you use to define prolonged mechanical ventilation? Because the guidelines are about those kids who need more than 24 hours of mechanical ventilation, but I'm sure that it's not the same as for a bronchiolitic kid to a neuromuscular disease sick child. I mean, what criteria or time point criteria do you use to define in your clinical practice prolonged mechanical ventilation? And when you say, well, this kid has already have a long period of mechanical ventilation, and you define that he or she is in prolonged mechanical ventilation, how do you manage those kids with high inspiratory drive? And how do you protect or try to protect the lungs of those kids?
That's a really hard question. So
Yeah,
I think the prolonged ventilation question, it just depends on what you want to do with the information, right? So we have a concept of prolonged ventilation maybe for epidemiologic purposes, just to try to understand, what the typical distribution is of ventilation and who the outliers are, right? Who the ones are that are the bigger problems, right, for us in our ICUs. So if I think about it epidemiologically, it's probably in that 7 to 10 day mark. And I think that, there's the long vent kids study, which is a big international point prevalence study that's ongoing, that's trying to define this exactly, this idea of what is prolonged mechanical ventilation. And, Atucci, Kawaguchi and Philippe Jouvet are leading that project. And hopefully we get some answers from their data. And I think they're using any patient that's over 7 days as inclusion, if I remember that correctly. And then they're looking at the full length to try to get at that idea of, where should that cutoff really lie from an epidemiologic standpoint.
But currently we are far away from that point of 21 days. Traditional 21 days.
That's right. That's right.
I think that in most parts of the world, we win and extubate patients in a much lower time frame.
That's right. That's right. I think 21 days is likely too long to think about that conceptually. And again, it comes back to what you're going to do with that information, right? So if I want to say, okay, this patient's had prolonged vent, if I think about it just from where we started with this discussion on the extubation failure risk, right? So in historical studies, prolonged ventilation longer than 14 days has been identified as a risk factor for extubation failure, right? Now, I think that's a surrogate, right? That's a surrogate for the physiology. It's a surrogate for the physiology of respiratory muscle weakness or ICU myopathy that might develop, which is of course higher risk in these patients that have been ventilated for a long period of time. But it could also be, a surrogate to the disease processes that lead to longer ventilation as compared to shorter ventilation, right? And that being a higher risk state for the patient to think about in terms of risk of extubation failure. So I do get triggered, right? Anytime that there's a patient that's been ventilated for more than 6 or 7 days to say, okay, this patient might be a higher risk physiologically for respiratory muscle weakness. I want to make sure I'm measuring that, right? And getting a good assessment for that as an example, right? So that's how I might think about using it on the ventilator liberation side, right? I asked another question, which is a harder question, which is, what do you do about these patients, let's say with ARDS, that have high respiratory drive that is persisting for a long period of time? I don't know the answer to that. It's something that we have to figure out as a group. I'll tell you what I do in my practice, right? And that is in the early phase of ARDS, in the first few days, I put the priority on trying to protect the lung as much as possible and reduce that respiratory drive. So I'll put the priority on good lung protective ventilation, which often will mean neuromuscular blockade for these patients that have very high respiratory drive, because then I can't prevent them. Otherwise, I can't prevent them basically from pulling high transpulmonary pressure or or having potentially high tidal volume, depending on the mode of ventilation that you're using. But once they start to get out of that hyperacute phase, those first 3 days or so, right, then I am gradually allowing more and more respiratory effort over time, so that hopefully you've broken that cycle by then, right? That they're not as severe as they were, when they're at the 7-day mark. They're not as severe as they were within those first 3 days or so. And I think that pragmatically, we have to find that point, right? To say we need to let them breathe, otherwise they're stuck, they're going to be stuck on this ventilator for the rest of their life, basically, if we can't, if we keep them under neuromuscular blockade for this long period of time. Exactly. So as time goes on, my thresholds get bigger and bigger, basically, of what I permit and what I allow. And I think it's also important, to think about this, especially as things go on and what tidal volumes we're willing to accept on some of these patients later, that we might accept a higher tidal volume target when they are breathing spontaneously, and a slightly higher driving pressure target when they are breathing spontaneously by a few centimeters of water, by 1 or 2 mLs per kilo, right? When they're, especially after those first few days, just to not have the flip side start to occur of a paralyzed patient forever that then you can't get off the ventilator.
So closer to 10 than to 6.
Well, it depends on their driving pressure.
Okay.
So if I'm going to allow up to 10 mLs per kilo, right? I'll do that if their driving pressure is still relatively low. So if their driving pressure is 14, 15, 16, and you can measure driving pressure on a breathing patient, right? If you can get an inspiratory hold and they relax at the end of inspiration, you get a plateau pressure and you can measure that driving pressure. And the adult data is actually quite nice about this. There was a recent paper that you and Goliger published that this concept that you can allow up to this 10, 11, 12 mLs per kilo of tidal volume on some of these patients if their driving pressure stays in that low range. And that makes sense, right? With that sort of physiologic hypothesis that those patients that have preserved respiratory system compliance, and this fits with even the PALIC recommendations, are going to be at lower risk for lung injury from high tidal volume because their compliance is preserved. Their FRC, functional residual capacity, should be preserved. So their lung stress and if their lung stress is safe with just the driving pressure in a safe range, you can tolerate that. So yes, in that kind of patient that has a low driving pressure, I will tolerate up to 10 mLs per kilo, for example, of tidal volume in that patient. If that patient, however, has very poor compliance and is generating a very high driving pressure, then that's the patient I would try to keep down a little bit longer.
Nice. Robbie, I have a last one for you. How do you manage post-extubation stridor? And do you use nebulized epinephrine? Yes, no, once the child develops stridor? Do you use CPAP? You try to avoid BiPAP, high flow? What's your clinical practice in those kids who develop stridor?
Yeah, so I think the first question is not all stridor is stridor. Not all post-extubation upper airway obstruction is stridor. And we showed this in our study that half of the patients that clinicians may label as having post-extubation upper airway obstruction actually have supraglottic obstruction.
Their tongue.
So they have, their tongue, their tonsils, their pharyngeal tone, right? Their secretions, these issues that are related more to neurologic control of the airway, for example. And those patients deserve a totally different treatment strategy than the patients that have subglottic upper airway obstruction, right? So the first thing I do is I do an airway maneuver. Okay, I do a jaw thrust with those patients that I'm hearing upper airway or I'm suspecting have upper airway obstruction. If it goes away or it gets dramatically better when I do an airway maneuver in a jaw thrust, then there must be some supraglottic component, right? So that's the kind of patient that, I'm going to look to say, are they too sedated still, right? And do I need to be more aggressive with weaning my sedation? Or will that patient benefit from some positive pressure like CPAP if it's supraglottic in nature, right? And if they generally have a response to an airway maneuver, then that's who I'm going to think about position changes in CPAP with. If it doesn't improve there, and I feel, yep, this is definitively, in the subglottic space, then I will absolutely give them a racemic epinephrine. And if they have a response to the racemic epinephrine, which most who have subglottic obstruction have some response, then actually what we have done, and this is totally off-label use, is we do a vaporized epinephrine you can use epinephrine with a high flow system, and it is continuously giving the epinephrine. There have been a few papers that we've published in our group about it that Kit Knuth has been the main author on. Just, I'll just say that there have been some patients where it's been remarkable that it really just sort of slowly helps resolve that upper airway obstruction over that next 24 hours or so, that you don't have to give them too many more repeated doses of racemic epinephrine. But generally they have to have at least some response to the racemic epinephrine before we would consider that. I don't routinely use CPAP or BiPAP in those patients with subglottic disease. Now, you can use high flow, and I do use it occasionally in those patients. One, as a drug delivery device for the epinephrine, right, if I'm doing that. But then theoretically, it might also help if you can, because so much of the upper airway obstruction, right, depends upon, turbulent flow and dynamic obstruction that may happen as they pull more. So if you can decrease their respiratory drive, and the high flow might be able to do that with a very high flow rate and washout of the anatomic dead space, it's possible you might reduce their respiratory drive slightly. That might prevent more dynamic collapse. So I do entertain it in some of the smaller babies, for example, that had a good response to racemic. Even if I'm not giving them continuous epinephrine, I might think about it in that group.
So if they do not respond to epinephrine, you go for the tube.
Generally,
if the respiratory is subglottic.
Yeah, we do use Heliox if their oxygen needs are low. Then I may try Heliox as well. And I think about it from the risk factor standpoint too. So I'll tolerate it a little bit more on a healthy patient with no other risk factors for extubation failure, for example, right? Then we're willing to try it a little bit longer, right? Because we think that over time, the patient will get better. If I have not given them steroids before extubation, then I will give them steroids after extubation, at that point. And then, hope is 6 hours by your time till the steroids start to have some effect, right? But if it's a high risk patient, let's say it's a patient with respiratory muscle weakness as an example, where I anticipate they're not going to be able to maintain that level of respiratory effort for that long, then those are the patients that probably end up getting reintubated sooner.
Well, Robbie, it has been a nice time chatting with you. Thanks for your work, and of course, this time with me. Just your final thoughts about how you envision the future of the mechanical ventilation liberating guidelines, and how do you think what is coming for us in the next few years in this area of research and clinical practice?
I think that what I hope that the guidelines have done is, sure, they've started a framework, right, for how we should be thinking about ventilator liberation. And I think that there are one or two areas where we probably have reasonable level of evidence to say, okay, this seems right, and we should definitely do this in our clinical practice. But as you can see, there were lots of other areas that were indeterminate, right? That you really could go either direction. There was a lack of evidence in a lot of areas. And I hope that if we redo this in 5 or 10 years, we're redoing it because we now have clinical trials in each of these areas. So I think it's hopefully set the stage for a research agenda, right? For all the beautiful young investigators across the world that are interested in doing some impactful clinical trials in pediatric ventilator liberation. There are a lot of areas that we need more evidence for, and that hopefully we can generate that in the next 5 to 10 years, so that when we come back to this, right, and we should, that's what you should do with every clinical practice guideline, is every 5 to 10 years you should think about updating them, right? Because our practices have changed, hopefully because of evidence, right? New evidence in these areas. And I think we see that with other clinical practice guidelines that come out, is it helps set the stage for a research agenda. So that's what I hope these do too.
Robbie, have a nice day. Thank you very much again.
It was a privilege.
Bye-bye.
Bye-bye.